Alrighty. Once again, thank you so much for joining us today as we are continuing our webinar series on community outreach, patient engagement, just different ways to really have a better relationships with our patients. This session will explore how cultural values, beliefs, language, and dynamics influence how patients perceive and respond to cancer screening messages. These presenters will share case studies, their strategies that they've used and observed, and tools to improve communication effectiveness in different communities. So, today, by the end of today's presentation, you should be able to describe how culture, language, and dynamics influence cancer screening communication. You should be able to identify at least two strategies that you can adapt in your health center and also learn how to apply different frameworks and tools that you can share to improve cancer screening conversations in your respective communities. So, again, I just want to welcome everyone to our series. I also want to say thank you to HRSA for funding this series, as well as I want to introduce and say hi to our BMG team, especially my co-facilitator, Tanya Davis, who's on here, as well as the other VMG staff and HRSA staff that might be joining us at this time. So thank you all for being a part of this. So now we're going to get into our actual panel. We're going to do our introduction a little differently today. So I'm going to actually say the speakers' names, and then they're going to actually give you their background when they answer the first question. Okay. So first we have Dr. LaShanta Eberhardt, and she's one of our first speakers. And then we have Erica Wanja Joseph. Next, we have on our panel Hawal Bajan, and we also have Singh Negalon. Next, we have Ariana Renee Britton and Dr. Sharon Atipo Dorical. So this is our wonderful panel today. So again, as they answer the first question, they are going to also give a little bit of their background. So that's how we're doing introductions today. And if you have any questions, feel free to again put them in the chat and we will answer them. If you are having issues with the chat at this time, please raise your hand. Let us know so we can help you with that. But again, you can ask questions at any time. All right. So going in the order of the introductions I just made. So Dr. LaShanta will be first. So the first question to the panel: what cultural values or beliefs most influence how patients view screening?
Well, good afternoon, everyone. My name is Dr. LaShanta Eberhardt. As mentioned, I am the founder and CEO of Thrive Now Consulting. And brief background about me, which connects to the question, is I've had the pleasure of engaging and partnering with diverse communities for nearly 2 decades as a public health researcher, primarily with my experience in cancer prevention and control working in communities. And so, what I found from the work that I've done in the past and I continue to do in the community is that the beliefs that most influence patients in the work that I've seen, and I've primarily worked with Black or African American populations, but also other diverse populations, I've seen largely issues around stigma and fear that had stemmed from how patients actually make decisions about their screening. The stigma that is associated, one, with conversations around cancer that really and is ensconced in how they make their decisions about their screenings. So that then bleeds into their behavior. But also, that stigma can be associated largely, I found, with beliefs and how one believes. It can be religious. It can be religious beliefs. And we've seen a little bit of variation in terms of what religion looks like in the Black or African American community. But things that have popped up and themes in my work have been related to Christianity and the church, or also beliefs utilizing holistic approaches when it comes to addressing health concerns, especially even when it comes to cancer. The last large thing that also pops up is thinking around that trust and mistrust of the healthcare system. And so that can largely stem from the historical context that's related to Black or African American populations here in the United States. And the history of variances, such as we think back to like the Tuskegee, syphilis study, and that still is relevant today as these populations are making screening decisions and even things like eugenics and how there's forced sterilization. But those experiences with the healthcare system begin to bleed into the beliefs and what Black or African American patients believe are important. And it may also vary when it comes to other populations. So that's just a little bit about my background, how I related to this thing, and what I do now.
Thank you so much. And I think you are next.
I am Eric Fondra Joseph, and I am based in Seattle, Washington. I do public health research academically, and I am a community engagement coordinator at Multi-Care Institute for Research and Innovation. Project that I'm currently working on is to increase BIPOC participation in clinical trials. And so I say the cultural values, just to piggyback off of Dr. LaShanta, has a lot to do with wanting to incorporate holistic care into their cancer screenings or when it comes to being screened for clinical trials as well. And then they also believe that religion is a very big part of that as well. So just really trying to incorporate that and then having that conversation about mistrust. I hear a lot about the Tuskegee, and also I hear a lot about like India and Oxford and talking to my communities. And so I think a lot of that is really important, and we just they just gonna have that conversation. So yes.
Thank you so much. I think next on our list was Ariana.
Yes, good afternoon, everyone. My name is Ariana Britton. I am currently a population health community health worker with a main focus in medical research. I am also a doctorate candidate at Liberty University, receiving my doctorate in public health sciences and a former clinical research associate. So I've seen both ends of the spectrum where individuals need cancer research and they need the cancer screenings, but they don't receive them. And I've also been on the end in community health where I'm dealing and experiencing these people every day who may have signs and symptoms but don't have the actual resources to get to their cancer screening appointments. I believe that cultural values and beliefs play a significant role in how patients view cancer screening, particularly in my field, community health. Participants feel as if they're unheard. So, a lot of the times in community health settings and rural communities where I serve, they're not being heard enough. The voices of our communities aren't being heard. And so they have this mistrust in the healthcare system because they don't see a lot of people who look like them and they don't understand health literacy and health education. In most communities, like what was said earlier, historical mistrust of medical institutions and medical doctors is a big thing in rural communities because they don't have the access that they need to these healthcare resources. And so if they don't have this access, their viewpoints and screening is going to be a little misconstrued because they don't have the capabilities to understand it correctly. As far as community health and community health workers, what I do a lot of is bridge the gap between project prevention and bridging the gap between underserved population and their healthcare. And I see a lot of individuals having this sort of stigma around the healthcare system, A, because they don't understand it, and cancer diagnosis is usually associated with something bad or something wrong going on. And so there's this fear of actually going to get screened because you don't want to know what's going on with you because you feel as if you not having the resources and not knowing what's going on is actually better. And then also in community health, we have something called social determinants of health. And for those of you who aren't familiar, your social determinants of health pretty much determines what type of healthcare you'll receive. So we're seeing a lot of our rural areas and communities lacking screening procedures that prevent care from occurring ahead of time, and a lot of them are actually getting screened and getting diagnosed in late stages because of this. So I think the culture in general to not only community health but healthcare as a whole topic and beliefs influence patients' view of screening greatly.
Thank you so much for your answer. And now we're gonna go to Hawal.
Good afternoon. So yes, I'm Hawal Bojuan. I would say just a bit of my background. Right now, I currently work as a health and wellness consultant. I come from more community health, health promotion type of background. A lot of my work has been in rural communities and, like I said, community health, just engaging, connecting, getting the resources, and I'm also a registered dietitian, so I bring the food aspect. I always tell my clients, I'm here to get you fed and nurtured. And that's my intro statement. And so they tend to light up when they hear that. And so just in terms of culture, I would say culture is extremely, extremely big. From working with the different cultures I've worked with and clientele, I would say one thing that did stand out was in terms of speaking about the cancer screening, speaking about it in a way it's like they're manifesting it. So that's been a cultural issue that I have seen working with the clientele. Like, okay, if I talk about it, then okay, it's going to happen. And so that's where I come in that we talk about in terms of the benefits, making it not to be such a big intimidation to the person and just making it feel comfortable, like it's okay for us to talk about it. Let's get that conversation going. I would say another impact has been in the traditional sense in terms of certain cultures being, because like I said, it's very intrusive, and so exposing yourself or your body, especially women, to the opposite healthcare professional it tends to be frowned upon. And so that is, so in that cultural context, some women are likely not to want to go for that screenings if they feel, oh, I'm going to have to be exposing myself to a healthcare professional.
Thank you so much. And next we'll have Sharon.
Hello, everybody. Good afternoon or good evening, morning, wherever you're dialing in from. It's great to be here. I am Dr. Sharon Atipodoku, principal of Tertia LLC, and the work that I do is to intersect evaluation, research, and design work, a little bit of artistry in there as a poet, and really have been fortunate to work across a gamut of projects, being with working with CDC, for example, over the past few years. And I will echo everything that has been shared around the impact of culture as it relates to, especially when it comes to cancer screening. Some of the work I had done previously is doing evaluation work looking at the role of community health workers, and we've heard about the impact of having that in the healthcare system. And the only addition that I'll add, because everything else that has been said is right there in my head, but the mistrust piece, however, mistrust and how it layers across not only the Black, Brown, and Indigenous populations, but we trickle down to really at the individual level in the culture, especially when it comes to immigrant populations, even within that demographic, it looks very different in how people perceive the cancer screening process, as well as even having access to it in the first place. So you have this dichotomy of, okay, sometimes I don't even have the access. And especially when you look at the immigrant population, where it's like, okay, I'm here to try and survive. I'm making money, so then I have to find time to go see the doctor, right? To give me some news that is not really great. So there's a lot of hesitation and being able to have these community-oriented models of care, like community health workers, like mobile clinics that we'll probably dive into a little bit, sometimes help bridge that process for folks to be able to be more amenable to live. So that'll be my take on the question. Thank you.
Thank you. And last but not least, we have Singer.
Good afternoon, everyone. I am Senga Galame. I am from Decatur, Georgia. I'm also in community health work as well. And in addition to community health work, I partner with a lot of organizations. I just get my hands dirty and find my way to help those who are in need. As a community health worker, I work with clients who are refugees, who are not from the United States, or who are just low income. For those who are refugees, who are not citizens, who want the health care, or who don't feel comfortable speaking because they know they're not a citizen, or they know that someone that doesn't look like them, that speaks their dialect, that understands them, and they don't feel like anybody will make them feel seen and feel heard. So I think it's very important for healthcare centers to have someone or have a translator or have material in their dialect, in their language, so they can feel seen, they can feel heard, and they can feel comfortable. There have been times where I've had to, even though I didn't speak the dialect for some people, I would piece words together and I would get them to talk, even if it was broken English, just for them to make them feel welcome and be that bridge between the providers and them, because they just gave up hope because they think no one cares for them, no one likes them. So it's just giving that impact, giving that extra mile, or just doing what you can to be creative, just so they feel like you are trying to help, and they're just not a nobody.
Thank you for that. Thank you. Thank you, panel, for doing your introductions and your backgrounds and answering the first question. Again, everyone who has entered the room a little later, Feel free to ask any of the panelists any questions. You can put it in the chat. We will read them out loud. And or if you have examples of what your health center is dealing with or something you have seen, please also put that in the chat. If you would like to speak on that, we will unmute you. This is really a very interactive panel discussion. So please, please, please use the chat feature, use the raise hand feature. We want to make sure everyone is heard today. So, next question, and this is for any of the panelists. How do modesty, gender roles, or fear of illness impact decisions? I know some of you actually addressed this in your opening question. So, if someone would like to take on this question, so how do modesty, gender roles, or fear of illness impact decisions?
This is Ariana. I'll answer because this deals a lot with social determinants of health and things that I normally see in my community health work. For many individuals, particularly women in healthcare, a lot of the times modesty and gender roles and fear of illness impact our decisions because we are supposed to be this feminine figure ahead of the family, have everything all together. And women, we're supposed to be strong and make sure we're who we need to be, not only in our healthcare, but in our real life scenarios as well. So, the fear of illness itself and gender roles and modesty, for some patients, the idea of being diagnosed with cancer or having a terminal illness, it just brings in a whole range of other things, such as financial burden or burdens to family members or having to seek out caregivers. In certain cultures, this is frowned upon. And then a cancer diagnosis may even carry that stigma that they don't want surrounding them. So, having a fear of illness definitely impacts decisions to go get screened for cancer and to go get help for not even just cancer, but chronic diseases in general. In the community health work that I do, a lot of patients avoid screening so that they won't have to go to the doctor and have to pay for medical bills because of that low socioeconomic status that they have. But they don't go to the doctors to also protect themselves emotionally and socially, as well as protecting their family members. So, in women in general, modesty and gender roles do play a huge factor. And although that kind of avoidance is understandable because people in rural areas are sometimes not receptive to receiving care that they don't understand or that they're not included in, late diagnosis and poor education also leads to bad outcomes overall. And so those decisions being made by the people in my community and in rural areas, for them, it seems as if they don't have another choice because they're the people that are supposed to be in charge of their own health care.
Thank you. Thank you. Any other panelists would like to hop on this question?
I'll just add one other piece around from the research perspective and how over time most of the research has not really focused on women as much, right? So just even thinking about the experience of going to get a pap smear, and if there are any biotech folks out there, this is a plug, and thinking about how going forward we can make these tools or equipment that actually deals with the body in a way that also respects that modesty, because sometimes just the way that the process goes, the equipment that we currently have, and I've gone through a few of them, and sometimes I'm like, oh my God, what are you doing to my body? And having all of those experiences sometimes can deter people from getting those cancer screenings, which is also thinking about from the innovation perspective, how can we think more from the research side and be able to address some of these things in the process of how we do new technology.
Yes. Thank you. Thank you for that.
I wanted to piggyback off of what she just said too, because she actually brought up a great point. Women are vastly underserved in the medical field. And so when we speak about modesty, we can also talk about how a lot of the doctors and OBGYNs and different cancer screening doctors are men. And so sometimes women feel uncomfortable getting those pap smears, getting those mammograms, getting those preventative screenings simply because they don't have a, someone of the same gender, and B, someone that looks like them that understands the healthcare disparities placed on whatever race or gender that they are. So I think it's very important to also add that in there. And I think that was a very great point that you made, Sharon.
Thank you. Thank you both. We're going to move on to the next theme, language and communication. So for this question, how has language barriers impacted your outreach or follow-up? So if you've seen examples, case studies, observations on how language barriers have impacted outreach or follow-up. Any other panelists would like to speak on this?
I would say with regards to the language barriers from what I've seen when I'm talking to both my clients in healthcare or even community health, when the person is communicating in a language that they're not fluent in, I saw quite a significant difference. The focus was so much on getting the words right to you and communicating and like, oh, my English is not good. And so it takes away from really the message the person needs to pass across to you as the healthcare provider. And so the focus was more on I want to get my English right to you versus I want to communicate my concerns. I actually want to do this regarding more of the health perspective. And so that's what I've seen. When we had interpreters or the person was communicating in their native language, it was so different. It just flowed effortlessly. It was so convenient. It's like they were almost dancing with it. And I was like, oh wow, And so for me, I'm like definitely having the person speak in their native language, it will help so much. They're able to share more and they're not focused on the challenges of not being able to communicate fluently in English. And they can actually focus on the concerns with regards to their health in that situation at hand.
Thank you. Thank you. Any other panelists would like to speak on it?
I would like to add is more of, in addition, as someone who does not speak English, but there are also those whose education levels are not the same as everybody else. So it's like you have to know your audience and study your audience. You have to use terminology that they're able to understand. You can't use a word and think that they're going to understand what you're saying if you don't break it down to the way that they're able to get it. So it's like you want to help, but you have to make sure you study, you learn your audience, make sure you bring the materials and information that they can actually take home and understand what they're reading. Because you can give a bunch of papers to a lot of people and they could just throw it away because they can't read it, they don't understand it. You don't know what reading level that they have. So you have to meet the people where they are and make sure the material you give them can be given to where they understand and they can take it to somebody else who can then pass it to somebody else and then the word gets out that way.
Thank you for that. Sorry, that's what I was gonna just kind of piggyback off of this. I was gonna say that language is more than just actually speaking like those language. It's about this style of talk that we do with our community workers. And I think a lot of times when people see that you apply in a healthcare system, they go in with that fear, or I'm talking to a doctor or someone in a white coat. Say I may not be able to communicate to them in a proper way. So I think we have to also
Having more having more options with regards to languages, interpreters. Like a lot of times, yes, you can always find a Spanish interpreter. When it comes to certain other languages, Mandarin, and even like certain African languages, it's really hard and very challenging. And with my colleague working with immigrants, they're speaking other languages that are not even Spanish, not any American language. It's like I said, it's a whole different. And so we're the interpreters for that. So finding interpreters that can translate and help with this would be great. I think just having more diversity with regards to the interpreters would go a long way as tools to help communicate.
Thank you so much. Again, audience members, those that are attending, you can put your questions or also participate in this discussion. Feel free to use the chat or we can unmute you. You can raise your hand, etc. So we want to make sure you all feel heard as well.
One thing that I think was not kind of mentioned was the cultural competency piece, being aware of not only the culture of the patient, but also the cultural competency of the provider. I think a lot of times when we talk about language barriers, we're saying the patient can't communicate, but we have to make sure that the language of the providers also maps on to the cultural understanding and values and background of the patients as well. And so though and Scottston, that is also the biases that sit within the system and the language that is communicated from that side. So I think that's really important when we think about the healthcare system, but also coming from the patient perspective. You have to meet them where they are. And I think someone made the point about interpreters. As a researcher, when we're building grants and things like that, we have to anticipate some of those challenges. And a lot of times we only think about that one language, but we have to think about making sure we're partnering with diverse organizations, other CBOs that can help us with those different dialects that sit within a particular language as well.
Thank you. Thank you. We actually got a question from a attendee And it really goes into the next question about what tools help teams communicate across language and literacy barriers. And this question says, have you all seen someone give instructions by video and animation to break through language barriers? So what has been a plus or minus to giving instructions by video and or animation to break through language barriers? So this comes from a attendee.
I've been successful with videos because I've
Oh,
I've done instructions with hypertension and also with diabetes. So the visual aid has really been successful for me. Also, when I've done sexual health education, I've done videos with that as well. And with the audience, that gives you because you can say so much to a person at one time and it's just not going to process. So, having that visual kind of just puts that icing on the cake to, like, really see where I'm coming from or what I'm trying to get you to get understand. Because you can say things for so long, you can give papers, you can give an explanation, but giving that visual and then do an example of it, like showing someone explaining how to take your blood pressure, showing a video how to do it, and then them actually do it themselves. So it's like it's in steps or just learning how to use your glucose meter. So it's just doing the visual, explaining it, then you trying it out. It flows. So that's how it's worked for me.
thank you. Thank you for that. Anyone else want to answer the attendee question, which is also the next question about tools to help your team communicate across language and literacy barriers?
I'll add to it. Yes, I've used video and animation as well. And I think in this times we use a lot of AI that's popping up. And one of my more recent projects involved the use of an AI persona. We initially started out with actually making animation of our team so that we were reflective of the community, but we decided to go instead with AI, something that could actually be personable and seem like a real person instead of doing like an animation. And that was successful to communicate information without telling someone that was AI. They didn't recognize that it was AI. And furthermore, we worked with the community to get feedback on what they wanted to see. So I think that's a big part of tools, making sure the community is a part. We always talk about CBPR, right? Community-based participatory research, but making sure that they're at the table when you're using tools, making sure you're using tools that are effective for them. And I think that really makes a difference when you're working with communities and language barriers.
I'm so glad you brought up both the AI piece and getting the feedback from the community because sometimes we just assume that it's going to work and we're good, but maybe not. So being able to have that collective or bi-directional feedback is important. And yes, to the AI piece, I haven't personally used some of the examples that you all have mentioned. However, I mean, the research shows that, the various ways of learning, right? And being able to make space for that is important. But when it goes back to the interpretation piece, because I get it, sometimes the access to having that specific language, dialect, what have you, can be challenging in a setting. So being able to leverage those AI tools, Google Translate, to even to start the conversation. I do that all the time in my personal work when, I'm working with somebody and they understand English, but perhaps cannot speak back. So we're over there typing on Google Translate and building that relationship that way. So there's a place for these tools in the work that we do.
Thank you. Thank you.
I actually want to add one more thing. This was an actual physical demonstration that I did because I've done mission work overseas to where a person would actually, where I taught about wash and flossing. So I actually acted out a skit of what would happen, like if you touch like poop or dirt, or even just showing like how to floss, like just someone spoke in Spanish, but I acted it out. So stuff like that is really helpful too. Yeah.
Well, we definitely want to see, well, not see more of the poop, but we would love to see more examples. You did this tool, and for those that are in the attendees, we will be having more of this discussion next week, and we'll talk about that later on. So I know we don't have much time today, but we'll continue this conversation next week. So let's switch to the next theme: community trust and dynamics. So let's talk about I know some of you in your introductions, you talked about the messenger in a community. We talked about faith-based, we talked about different community leaders, especially on at Tuesday's webinar. If you missed Tuesday, you missed a treat. But we talked about who are those messengers that you should really build a relationship with in order to reach the population to get them screened. So for this question, who do you feel, who have you seen are the trusted messengers in your various communities?
Hi, Ariana here. I'm a community health worker again, and I do a lot of community based research. In my experience as a community health worker, I've become one of the messengers by bridging the gap between underserved populations and their healthcare resources. And some community members that I've made it my mission to get close to are local government officials, local health departments and state agencies, coalitions. We've used our public libraries and a lot of public spaces where people are gathering, where we notice there's a lot of them there. Outside of that, we have used churches and faith based leaders to get the word out about certain programming and community health events that we have. We've used parks and recreational centers, local YMCAs. When I say we bring the healthcare to the community, that's what we do. We make sure that we're building these relationships and partnerships and establishing things with people who are already in the community so that we can kind of build that trust with the community, because in rural areas in particular, trustworthiness is everything. They love when people come in and they already know about the community and there's no stigma or bias behind it. So when we utilize the people that are already in the community, that just adds more comfortability for us to get our point across regarding healthcare. So those are some of the trusted people that I have used.
Not agree with you more. Sorry, I was gonna say some of the trusted members that I've reached out to have been hairstylists, beauticians, because we have a program in Washington where hairstylists are able to be trained as peer mentors. So they kind of talk to them about mental health issues. And so I figure, well, why not have them get that training as well to talk to them about cancer care and cancer screening? So especially in the African American community and the marginalized women, we really depend on our beauticians. They're almost a part of our family. So why not get them the same training and education to have that conversation as well?
So just to piggyback, did you say they're peer mentors or they're like patient navigators?
So in the program that's already established, they do more like mental health work. So help to help them become more like patient navigators, surrounding pain is free, and getting them introduced to clinical trial information as well.
Thank you. Dr. Sharon, I see you have something. And then we also have a question in the chat. So after this, we have another question, which is great. Dr. Sharon?
I've been real quick and we'll go to the question. But no, I completely agree. The theme here, and that's part of the work that I do, is that bringing to the patient perspective, right? And the whole notion around access and what that looks like, it's very much broad. It's not just being able to afford or being able to even go, but even geographically, what is the proximity of being able to have the patient have these abilities to be able to go? So community health workers having the community-based folks that are already a part of the trusted network. And that's where things like or models such as mobile health clinics also play a great role in being able to bring the service to the community rather than them trying to find where to go.
Thank you. Anyone else want to speak on this question before we go to the question in the chat? All right. Taya, would you like to read the question in the chat, please?
Okay, so it looks like the question is what contextual factors should be prioritized when engaging men in cancer conversations, particularly given the cultural norms, stigmas, and perceptions that often influence their willingness to seek care or discuss health openly. So if I was to summarize, it's basically how do we get our men to get out for their cancer screenings, and how do you hold a conversation?
Who would like to tackle that first?
For me, this is personal, right? Because I'm a wife and have two babies, so all those conversations happen internally in my own home. So I think sometimes just looking from it again back to the word proximity, who is around those individuals that need to speak to them that they trust, and it'll look different. Sometimes it's a spouse, sometimes it's a very good friend, right? And being able to have those individuals, because when I go to my doctor's visit, it's not just my visit. It's like planning for my husband to come for his appointment too. So there are ways that we can leverage proximity and people who are in proximity to our men to be able to take care of themselves.
No, same. I would agree. I have this conversation with my husband all the time. And so I'm in the same area. But when I think about like men in conversations, contextual things, you have to tap into the cultural norms. When it comes to masculinity, you have to think about their vulnerability when it comes to a diagnosis and making sure they have a trusted person that they can lean on, whether that be a spouse, whether it be a significant other. That could be also another man that they can confide in. But also like any stigma that might be associated with a certain type of cancer, since we're leaning into that. I've take prostate cancer, for example. Some of the work I've done is, we lean into having the exams but we're not thinking about what masculinity looks like, even for men that may not identify the same as other men, right? So you have to take into the layers that come into that are we woven into masculinity for men and who they have in their corner to support them in that journey. So I just wanted to add that on top of what Dr. Sheets.
Thank you.
And just to add to that, I would say even siblings. So I would say siblings bringing up that conversation, bringing up the conversation early on. Just whoever they're around, who's that person? Like I love what you said about the proximity. Who's the person they're around that can bring up the conversation to talk about it? Because if it's not talked about, there's a high chance the person might actually not even bother. Just from my experience. So I talk about it with my brother, like, oh, bro, have you gone to your animals? Have you had a checkup and everything? And so having a conversation got him to be thinking about it, like, oh, yeah, that is true. I do need to schedule. I know you're busy, bro, but I do want to keep you here longer. And that's like, and it's like, okay, I'll work on it. I'll work on it. And then you follow up. Don't just stop there at that conversation. You follow up again. And at some point, the person will just, okay, I've made that appointment. I get it. And so that's what I'm saying. Like whoever, whether it's a cousin, whether it's even a close friend, who, having those conversations, whoever in that proximity level, just bring it up. Get the conversation flowing and talking about it. Get the screenings, get it done. Certain age, oh, we need to get that going. We gotta, health is wealth. And just still comments on that.
Thank you. Thank you so much. Again, the chat, the question and answer box, everything is open for the audience. So if you have any questions, any comments, any experiences that you're facing in your health center, please let us know. We are almost at time, but what I want to do before we move on to the next section, I think we have a question. I got excited. The question is, how do you make sure cultural preferences are respected when nutrition and education plays a big role?
I can start to tackle that.
Okay.
There's an organization here called Open Hand in Atlanta, and they actually have because I guys mentioned I work with the Hispanic population, and there's actually an instructor that actually teaches individuals, the Hispanic culture, to cook their dishes in a more healthier way, control their diabetes, control their blood pressure. But at the same time, the same foods that they like to eat, they can learn how to make it in a more healthier way. So I do think it's important also that helps, but then also understanding a way to teach those who have certain dishes that they like to eat to how to prepare it in a more healthier way.
Thank you. And I know we have someone who studied nutrition and there's a dietitian on this panel. So would you like to speak on that?
Yes, absolutely. Yes. Well, thank you. I love thank you for that question. I love the word too. When, like I said, when I tell I'm here to get you fed and nourished, they start to smile because they haven't heard in a while. So I live by that. And I would definitely say when you're talking about the nutrition, the food, our it's psychological. I was talking to a cancer patient, like you're meeting some of the cancer patients I'm with, loss of appetite and just not wanting to eat. It is psychological. How the food looks can appeal to you or can turn you off.
Mhm.
The color of the food, the way, the appearance, the food might taste delicious, but the way it was set up, do I even want to go there? Exactly. So it is a psycho and you know, when I was telling the pa when I was sharing that with the patient hadn't thought about it, like, "I didn't think about it psychological." I said, "It is." You know? There's certain foods we see, we get excited. You're just, like, turned on by, like, "Ooh, I want this right now. I'm gonna demolish this. This is it for me." You know, and then after you eat that, there's a satisfaction you feel, a feeling, a nourishment you feel after eating that meal. And so incorporating the person's cultural food will get your attention. Never do away with their no, they've been eating that cultural food for years. Why would you suddenly say, "Oh, you have diabetes now, you can't eat that." No, it doesn't work that way. Factor their cultural foods in it. The client respects you more and they're more open-minded to even want to eat this food. Pick your cultural foods that align with their diet. It goes a long way versus telling a person you can't eat carbs, you can't eat this, you can't eat that, then what can they eat? That's the question. You know, nothing after you've listed everything, you know. And so for me, when I talk with them on that perspective, I always factor in, depend on the culture, whether the person is African and specific to even the African cultures, the different countries, or the person is Middle Eastern. Go specific to the actual person's culture and incorporate that in the diet education. It really, really goes a long way and it's very impactful in them adhering to the diet and just, you know, picking and choosing healthier options.
Thank you. So you're saying they can still have jollof rice?
Yeah. Oh, listen, tear it up.
This is Ariana here, and I just want to reiterate the fact that ultimately we need to frame our conversations based on who we are talking to and the community that we are working with. We want to do this in a way that not only honors the person's values, but honors who they are as people and individuals. And so when we're talking to these people about cancer screenings or chronic disease screenings, anytime we're talking with a community, we need to make it clear that prevention is a strength. It's not a weakness. And actually going to the doctor and talking about your healthcare isn't a bad thing. And so if I could leave you all with anything, as a community health worker and medical researcher, it would just be to try to understand your community better. Try to understand the individuals in your community and target them in a way where they can understand how to live happy and healthy lives.
Thank you.
So I'll add to that. That was a great one, Ariana. And to add to that, also thinking about collaboration with the community. So that could mean collaborating with different individuals with expertise in the field, bring a dietitian in if needed, that type of collaboration. And even more importantly, also thinking about, let's look at the spectrum, right? It's screening through getting the diagnosis, through getting treated, and going through that journey with a patient. So there also different touch points so you can leverage those experiences as part of how you're able to work with individuals that may not be so adept to wanting to be screened. So those individuals who have gone through the process can also be champions to encouraging screening processes.
Thank you. Anybody else have any parting words for our attendees?
So for me, I'm going to share for those the community workers that are in communities that you're new to. So for me, a lot of communities I moved to, I was new to it. I wasn't from there. What was very helpful was find out who are the stakeholders in that community. Connect yourself with the pivotal people in the community. It helps so much. I was at every community health and wellness event. I was at every event you can name in that community. I went to different organizations, their location, and just introduced myself to get the program implementation going. So I feel like getting out there, just immerse yourself, wanting to know. They loved it. Like you're a newcomer, so it's like, okay, they're getting a feel of you, like, who are you? Okay, are you really about our community? Are you here for us or you're against us? You know, so you want to show that, listen, I'm here to support the community. That form of servitude, it really helped a lot. And just like I said, immerse yourself and throw yourself in every part of the community to build your network so that you could also get conversations going, also be able to recruit and get more clientele to, you know, partake in screenings. And I love what Dr. Sharon said about networking. Network with others, it really gets a bigger outreach. It really works well. It recruits more because only it's not a one-man job. It's a collective, collective work, and group role that we have to do.
Thank you so much. Okay, so I'm going to turn it over to Augustine, who is going to discuss our next events that will be happening next week. So, Augustine, you can take it over.
Okay. We have some exciting events happening next week at BMG, starting off with building relationships and screening conversations. This will take place next Tuesday, July 29th at 1 p.m. And then following that, we have Outreach That Works, text calls and home visits. This will take place on Wednesday, July 30th at 12:30 p.m. Also, we will have links to these registrations in the chat. So if you'd like to register right now, feel free. And then last but not least, next Thursday, July 31st, we have partnering with colleges and universities to fill staffing gaps. So exciting opportunities and exciting events upon us, and we hope to see you there.
Thank you, Augustine. Tanya, do you have any last words before we dismiss?
Oh, yeah, I would just like to say that this was really, really great panel that we have here today. So many rich tips and input, and sharing so many valuable experiences. I want to say kudos to Dr. Nicole Dixon Weathersby for being an amazing moderator. Let's give her a hand as well for keeping the conversation going. And then thank you to all of our attendees. We appreciate you taking time out of your day to join us as we all come together to look for more ways, more creative ways to expand cancer screenings, get ahead of the problem that we have in our nation, making sure that patients are diagnosed early because we know that early diagnosis, right, leads to better outcomes. So thank you, each and every one who's taken part in this initiative. And enjoy the rest of your day. Thank you, and we'll see you at the next one.
Yes, see you next week. Thank you, everyone.